welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, 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 and happy Monday. It's Dr. Mitzi, the nerdy neurologist, and I am so excited to be here with you for another episode of Brain Chat with the Nerdy Neurologist. So this year we are expanding our horizons just a little bit. We are talking about MS, but we're also talking about other common neurologic conditions, some of which affect people living with MS and some of which affect the general population. So today I am so excited to have two amazing movement disorder specialists with me, and we are going to talk about tremor. We're going to talk about Parkinson's disease. We're going to talk about a couple different things, but we're going to get into it, and it's going to be a great conversation. And so let me welcome to the platform Dr. Chantel Branson, who is an associate professor of neurology and also the program director of the neurology residency program at Morehouse School of Medicine. Welcome, Dr. Branson. Welcome back to Brain Chat.
Thank you.
Awesome. And we also have Dr. Joash Lazarus, who is a fellowship trained neuroimmunologist and movement disorder specialist, and also is the director of clinical research at the Atlanta Neuroscience Institute in Atlanta, Georgia. Welcome, Dr. Lazarus.
Thank you, Mitzi. Thank you for having me on here.
Awesome. Okay. All right. So listen, on Brain Chat, we talk about a lot of different topics, but before we get into it, I always want to know what drove you to go into the field of neurology. I think it's really important for people to hear your stories and hear what got you interested in neurology and what got you interested in movement disorders. I'll start with you, Dr. Branson.
I really loved neurology in general, and I didn't know I wanted to go into movement until I started my residency program. But I will tell you, some of my most best awesome mentors were movement specialists. They were just fun. I feel like we are the most fun people. We have a great time, and we get to learn about movement, which is very intricate. It's different, it's unique. There's not a algorithm that any one person can follow, which we'll talk about more shortly. And it's just very nuanced. And I really love that part of becoming a movement specialist as well.
Awesome. And what about you, Joash?
Mitzi, that's a great question. So growing up, my dad was or is a neuropsychologist. And so from really young, I would follow him to work. And I became fascinated kind of with the neuro behind the science behind kind of neuroscience. But it was really only when I was a medical student and unfortunately my grandfather had a stroke that a few things hit home. And the biggest thing that hit home was how pervasive neurological disorders are.
Yeah.
We don't really treat the patient as much as we do the whole family and sometimes the community. It has kind of a ripple effect. And that kind of stuck with me. And I wanted to pursue neurology, and movement disorders just grew on me because it's so clinical and because the ripple effect you have over a family and their loved ones just by treating sometimes one symptom or one symptom complex. And the most exciting thing in Dr. Branson in my time is that the field's changed so dramatically from something we just kind of diagnose, it's diagnostic field, to a real interventional field, which we'll get into. So that's been the most exciting thing for me.
Yeah, that's really exciting, and of course I always talk about, my interest in neurology, but I just knew when I went into the field that there was so much potential for change and growth. And I was like, in the course of my career, this stuff that I'm learning now is going to be completely different. And it's been so amazing to actually see that happen, to see the ability to treat people, to manage neurologic conditions just change so drastically in a short period of time. So I always think of neuroscience as the cutting edge of science. So I know I picked the right thing, and I definitely am not regretting it at all. So let's talk a little bit about what is a movement disorder specialist. So I've been doing this series of like 1-minute videos, just kind of describing what are brain doctors, right? Because a lot of people call themselves brain doctors. So, talking about the difference between a neurologist, a psychiatrist, or a neurosurgeon. And then I've been doing a series talking more specifically about different subspecialties of neurology because many people see general neurologists, and there are some amazing, amazing general neurologists out there in the field. However, there are many, many more subspecialties of neurology. And so I think it's important for people to know what subspecialist treats which condition. So, what does a movement disorder specialist do?
So, Betsy, a lot of neurological disorders can impact human movement in general. Walking is a
Hmm.
good example of that. But there's a subset of disorders in which those symptoms are the preeminent symptom. They're the most visible type of symptom. And so I guess Dr. Branson and I, as movement disorder neurologists, tend to focus on diagnosis and treatment of those disorders. Another way of looking at it is that a lot of those disorders are degenerative. And so, in many ways, we tend to focus on a lot of degenerative problems. But broadly speaking, good examples are Parkinson's and Parkinson's related disorders. Essential tremor is very common. And then some genetic disorders as well, like ataxias and dystonia,
Hmm.
are movement disorders.
Yeah.
Yeah, just to add to that, when we talk about degenerative, we don't typically put the essential tremors or anything like that in it. It's more of what we used to call benign in the past because it's not typically associated with memory problems as they get older or further along in the disease process. So we most commonly see people with really different types of tremors and shaking. And the biggest question we're asked is this degenerative? Will this become degenerative? So we, all types of different movement disorders, clinicians, neurologists, and other people come to us to help us distinguish what type of etiology or cause that they may have.
Hmm. Yeah, so I'm hearing definitely tremor, certainly Parkinson's disease. One of the hallmark symptoms is tremor. So sometimes tremor can be diagnosed as Parkinson's, and then other ataxias, which we're going to get into what those terms mean. All right, so let's start with tremor. So a lot of people come to see me. So I do a little bit of general neurology and mostly MS, but I have a lot of folks that come to see me with tremor. They're like, Dr. Mitzi, I'm shaking, and so let's talk a little bit about some of the most common cause of tremor, common causes, and then let's talk about those that we would consider benign, as you said, Dr. Branson, meaning there's not like a overarching disease, or something degenerative that'll progress or worsen over time, versus those where we need to be saying, hey, we need to be getting this checked out because there might be something else going on here, like a Parkinson's disease or some other disorder.
Yeah, I can start with that. A essential tremor typically is the most common one that we see in the community. It's usually 50% of the time associated with a family history,
Mm-hmm.
and it starts earlier on in life, and it usually doesn't progress as much. There is some progression. Of course, as people get older, they may notice that their tremor occurs more often, but it also is most commonly associated with tremor with action, meaning movement, meaning they're holding a cup of water, they're eating, or doing some activity, getting dressed. Those activities or movements can affect them. It can also be associated with anxiety. Usually, the tremor comes out when they're around a group of people at a dinner and they're eating and chatting and they become a bit self conscious about it. Sometimes it can affect the work that they do if they're painters and things of that nature. So that's the most common one that we talk about that is not a part of that neurodegenerative group.
Hmm. Yeah, and I have a lot of folks that come in with essential tremor or ET, not extraterrestrial, but essential tremor. So I have a lot of folks that come in with it, and do note that one thing potentially makes it better. What makes it go away? That's not recommended as a treatment, but a lot of people say there's one thing that makes it go away. What's that?
Yeah, we do. We do ask, does alcohol improve your tremor? And that can occur. We don't recommend that
That's
over
not a
the
treatment now.
long
Dr. Mitzi did not tell you to go out and drink and make your tremor go away. Let's be clear. But I have, that is a common thing that people say that they notice, when they drink, it gets better. And I've had some folks who said, listen, it's getting worse. And I can't drink all day, so can you help me and give me some medicine so that I, can find some other way to deal with it. So essential tremor. Dr. Lazarus, tell us about, what other are some other causes of tremor that may be, certainly a bit more concerning.
Sure, so there are other medical issues that could lead to tremor, even
Mm-hmm.
transiently. The common ones we'd see are problems with thyroids or hyperthyroidism, for
Mm-hmm.
example, much more than hypothyroidism. Medications definitely do, and the ones that are most commonly implicated are antidepressants or psychiatric medication can, and even blood pressure medicine can also, to some extent, or asthma medicines that we used in the past. And then very commonly, steroids are used for plethora of disorders, and they can, during treatment, trigger involuntary movements, tremor being one of them. In
Mm-hmm.
general, those tend to be somewhat easier and palatable to manage in that you treat the inciting cause. But to answer your question about the tremors that we're more concerned about are the ones that are evolving into a more degenerative process, we would refer to it as, and Parkinson's is the one that we're concerned about in that category. As Dr. Branson mentioned, the essential tremor tends to be during action, so eating or writing are good examples. And while that can be the case in Parkinson's, one of the key features is the tremor at rest. So noticeable, for example, when they're watching television or having conversation, it's hands rested, not engaged in any position or posture or activity specifically, it becomes more noticeable then. And at that point, it's really a visible sign, a harbinger of something else, a syndrome that's much more than just a tremor. And so
Mm-hmm.
identifying the underlying cause, the etiology becomes much more pressing for us at that moment than it does, for example, essential tremor.
Yeah, so I mean, so many important things that both of you said, but definitely you have to think about medication. Sometimes when we're treating one thing, we could cause something else to arise. So it's important, if someone develops tremor, to talk with their doctor and kind of run through if there are things that have changed, if there are new medications, and they can test, for those labs and other things, etc. So what are some of the treatments for tremor? So we know that drinking on a regular basis is not a treatment for tremor, but what are some of the ways that tremor can be treated, for those who are having this issue?
So as we talked about a little bit, there are different categories. So when we talk about essential tremor, the treatment for that most commonly is a medication called propranolol. It's almost like a blood pressure it is a blood pressure medication, antihypertensive. We don't use it for that. We've noticed that anecdotally, or not even, we've noticed that there are papers that have shown it helps with tremors and shaking. It also helps a little bit with that situational anxiety that I was talking about before when people are out with their friends and they're eating dinner. That also calms them down a little bit. And then there's another medication called primidone that helps as well. So either one or two of those medications, we're a bit limited on the treatment options for essential tremor. We do have a newer non-invasive procedural type of treatment as well for essential tremor. But that's pretty kind of new. Well, not really. Focused ultrasound is what we call it. And that also is a treatment for essential tremor.
Hmm. Now, what about, since I do, see a lot of MS patients, sometimes I do have MS patients who have a very severe tremor that we call a rubral tremor. So, for those severe tremors in that case, are the treatments the same, or are there any other additional treatments that may help with that? I'll throw that to you, Joash.
Yes, a good question. It's a different type of tremor entirely. It tends to be a little bit more visible. The word we use sometimes is more aggressive, almost violent looking in severe patients. And it does not respond, unfortunately, as well to the same medications, but we'd use or we'll trial the same medications. And sometimes one or two anti-epilepsy, anti-seizure medications can also help.
Hmm.
The efficacy of those in essential, compared to essential tremor is unfortunately much lower, depending on the patient. And they have not been, to my knowledge, studies of the focused ultrasound in those patients as yet. There are very few studies using the surgical procedure, deep brain stimulation, to help those patients. And it's not as successful as essential tremor. So in essential tremor, the outcomes can be really very good. You can really control the tremor quite substantially, at least for a few years with DBS. And then you have the potential to adjust the stimulus and adjust the setup so that you can control it if things were to progress. But very few studies have shown like real promise in cerebellar tremor because it's a little bit different from the essential tremor in MS.
Hmm.
It's unclear if it's because the MS was progressing at the same time, and so the tremor is worsening or not. But I will point out, because I have looked at this recently, is that there's very few recent studies, which is important because MS therapies have really evolved over the last 5 or 6 years. And so maybe you're having a relook at those same interventions now with better MS therapies, it would have a better outcome. We don't know really the answer to that.
Yeah.
Yeah.
Yeah. Go ahead. Go ahead.
Just to add to that, we threw out a couple of terms: cerebral, cerebellar, rubral, and these are typically tremors that occur with rest and action. So you'll see people shaking. The frequency or high, fast, or how big the movements are can
Mhm.
change, and that really distinguishes or helps us to determine if it's essential tremor, or Parkinson's disease, or any of these other types of treatment. In addition to the diagnosis of MS, but that may be the first finding or
Mhm.
symptom with people who have MS. So
Mhm. And what about the role of things like, I know it doesn't necessarily treat the tremor, but what about the role of things like occupational therapy, wrist weights to kind of dampen the tremor, or weighted utensils? Are those things, are there, occupational or other things, devices that people can use to help maybe dampen it a little bit? Are those things useful?
They can be. Occupational therapy particularly can be helpful in dystonic tremor. So patients
Hmm.
who have a little bit of tremor because of posturing, abnormal posturing, or the cerebellar tremor that you would see in MS. To my knowledge, there's also a tremor pin that's been really helpful for some patients.
Tell me a little bit about that.
It's weighted in such a way that it helps to stabilize the patient when they're writing.
Mm,
In general, in a lot of tremor patients, we use the term tremor sometimes synonymously with essential tremor. But when we're addressing those patients, because we have pretty good therapies like EBS or focused ultrasound, like Dr. Branson mentioned, we tend to focus a lot of our attention on trying to get accessibility to those therapies because they work so well. Uh,
yeah.
and so, at least in my patients, they do occupational therapy for a short course, which really helps. But a lot of them do well beyond that, even without the need for like long-term therapies, which is very
Hmm.
different from Parkinson's disease, for example, or MS per se,
Yeah.
where it's an ongoing relationship with the therapist. You know that they're going
Yeah.
to those needs.
Yeah, those are all great points, and tremor, can be very common, so I think it's important for us to address it because a lot of people. Now, tell me about your exaggerated physiologic tremor. So I got a lot of folks that come in and say, Dr. Mitzi, and they're like, oh, and I'm like, well, if you hold your hand long enough, everybody's got a little bit of tremor there. So tell us about like the physiologic tremor and what that means and what that looks like.
yeah, we usually see these in people who have, they can either have anxiety, maybe how asking how much coffee they drink. Can be associated with caffeine intake. Sometimes we want to make sure, again, we talked about this earlier, or Dr. Lazarus did, about ruling out something like a thyroid problem, especially
Hmm.
with hyperthyroidism, because that can look very similar to that. So these are people who my coffee drinkers who are
Hmm.
worrying at night and can't sleep, and they have a little bit of that physiological tremor as well.
Hmm.
But when you remove, ideally, the the problem, it resolves or improves, such as treating the anxiety or decreasing the amount of coffee or caffeine that they drink or take in.
Yeah. Yeah, absolutely. So I think, I wanted to point that out because I have a lot of folks that really have like a little bit of exaggerated physiologic tremor, and can be concerned. All right. So moving on from tremor, let's talk about ataxia. All right. So what is ataxia? So let's first talk about what it is. What's ataxia?
No, we use the term ataxia for poor coordination, and often that
Hmm.
comes with a couple of things. It comes with balance problems. But in general, these patients have a number of symptoms, the way they visibly express themselves. They have, slurred speech, problems with coordination in the hands, walking and balance problems. And it
Hmm.
can be a symptom of another disorder, or it can be a category of disease by itself, which, like we mentioned earlier, is degenerative. So we try to uh, draw a distinction between them.
Hmm. And so what about, is this when people come in and say, "Hey, I'm walking like a drunk person," or I feel like what are the common complaints that people would say, right? Cuz they don't come to the office and say, "Hey, doc, I got ataxia." They say, what do they say when they come in, or what are they noticing or saying that brings them, to see the doctor or see the neurologist?
Balance problems, I think, and walking problems would be the most common example.
Mhm.
Um, Writing problems, coordination problems are the other. Much less commonly, slurred speech would be the thing they noticed first, but that can be associated with it as well.
Hmm. And so, how do you? What are the treatments for ataxia for imbalance or these issues, or how or what are some of the most common causes?
Yeah, we typically uh, deal with the degenerative part causes, so
Mhm.
something that's like a spinocerebellar ataxia, which is genetic cause. So most commonly, people may have a family history if they have a relationship, or some people may not know that they have a family history. And we can see that varying ages depending on when the family member prior to that had developed the symptoms or
Hmm.
the genetic outcome of that.
Hmm. Yeah. Do you usually see those genetic things in children, or can you see them in grown-ups too?
So, a lot of them actually become visible as adults. There's a
Mm-hmm.
few of, we call them SCAs, that are become visible in the teenage years, but unlikely. Well, we don't really deal with the childhood ataxias, but there's a group of
Hmm.
them. But the other causes for ataxia, so medications
Hmm.
can definitely cause that, and in children or younger patients, seizure medicines are known to be associated with that quite a bit. Anticoagulation medicines, so patients on those, and then alcohol is probably one of the biggest cause for ataxia that's acquired that you have, generally. The other cause I think later on in life is stroke. So patients who have
Hmm.
a lot of vascular problems can definitely lead to ataxia.
Yeah.
And then
Absolutely. Go
one that
ahead. Go
I
ahead.
don't think we talk about often is gluten ataxia.
Mhm.
That is one that people don't realize it is, could potentially be a problem as well.
Hmm. Yeah. You said gluten ataxia.
Yeah,
Okay.
yeah.
They're
So,
allergic to gluten.
well, the theory or the thought is that the gluten occurs, not that they're allergic to it, but it attacks the different part of the brain that can affect your balance or movement.
Okay. Okay. And the treatment for that is to remove gluten, like from the diet. Okay. All
Gluten free.
right. Okay. 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 We're getting into it. Dietary things. Yeah. So, again, I think, it's important for people to understand that, these are some of the medical terms that we use, but these are very common issues that can occur that people just may not know the name for, that could, be related to medication. Sounds like medications are a big culprit. So being careful about, what you're taking. And that's one of the reasons why I don't like to start multiple medications at one time, because if one is causing an issue and I start three or four, I don't know which one is causing you the issue. But certainly medications can be a culprit. Sometimes, other, issues can be a culprit as well. So I think, it's important for people to have the language to describe the symptoms they're having and understand, who, is the subspecialist that really treats and focuses on these conditions. So let's move on to Parkinson's disease. So this is one of the big or primary diagnoses that I think of when I think of movement disorder specialists. And I think it's important because it does affect, I think many of us know somebody who has Parkinson's disease. First, I want to talk about what is Parkinson's disease. And then I want to talk about the difference between Parkinson's disease and Parkinsonism. Because people can have some symptoms that are similar to Parkinson's disease, but it actually is related to another condition or could be related to medications. So let's talk about what is PD and then what's the difference between Parkinson's disease and Parkinsonism.
So PD itself is a degenerative disorder,
Hmm.
and really it's caused by accumulation and clumping of abnormal protein in the brain that really shouldn't aggregate, shouldn't clump up in the brain. And so we call that a synucleopathy because that's the name of the protein. And when
Hmm.
it does so, it accumulates in areas that control movement. And so the diagnosis is very much clinical. It's based on what we see when we examine a patient and the story we hear. But we use the acronym sometimes TRAP. Tremor is a good sign of that. Rigidity or type of stiffness when we examine them, very slowed movements or akinesia, and then balance problems, so a partial
Hmm.
disability. And generally, Parkinson's disease is accompanied by the slowness and at least one of the other symptoms. More recently, we have some diagnostic tests that we can use when the clinical picture isn't quite as clear. We can test for that protein, not directly in the brain, but in the skin, because we've found through research that it accumulates in the skin coincidentally with the brain as well. And when this protein accumulates, it reduces dopamine, which is a neurotransmitter in the brain. And dopamine is really responsible for numerous things, but one of them being well coordinated movement and well consolidated movement. And so when there's a loss of dopamine, you have the uncoordinated excess movement like tremor or very slow movements in different parts of that circuit. And so a DAT scan can scan for dopamine, the cells that produce dopamine as well. And
Mhm.
generally in Parkinson's disease, they're lost. So an abnormal DAT scan can help us with a diagnosis as well.
Yeah, I mean, so how common is Parkinson's disease? So, I always think of Michael J. Fox. I grew up with, watching him on television, on all his various shows and movies, Back to the Future and all of those things. But how common is Parkinson's disease in the general population?
Based on the data that I've looked at, and Dr. Lazarus, please correct me if this is not correct, but about 1% of the population have Parkinson's disease.
Mhm.
And we know that that is increasing as people get older over time as well, that it's predicted to increase to about 1.2 million people in 2030. And that thought is because we're getting older, we're living longer, and people are, because this, again, we're talking about a neurodegenerative disease
Mhm.
that occurs most commonly in people who are over the age of 65.
Mhm. What about any risk factors? Are there any risk factors, whether they're modifiable or not modifiable?
Yeah, so there's certain genes, so genetic factors that are associated with the disease, but the genetic factors account for probably less than 10 to 15%. So the
Mhm.
most cases of Parkinson's are idiopathic. There are
Mhm.
some risk factors which are toxin exposure, so certain pesticides, for example, BPPA is another, um, Agent Orange in patients who served in
In
the
the
war, for
military.
instance, have
Mhm.
known to like increase the risk, but we still don't have a identifiable solid cause for the disease. Still idiopathic. We call it idiopathic because there's no real known cause for it.
Yeah. Yeah, I mean, so very similar to MS, right? We don't know what causes it. There are some genetic factors, there are some environmental factors, but certainly, we don't have anything that we could put our finger on, or we don't have a gene or antibody that we can test really, to give us the etiology or the cause of it. So what about treatment? So how do you treat it?
So treatment varies based on each individual, and we have a large number of medications and options for people. What we typically try to treat is that dopamine, as Dr. Lazarus was talking about, it decreases over time, and we want to increase as much dopamine as possible. So the main treatment we have is carbidopa levodopa. The levodopa is the one that we want to get to the brain. Carbidopa helps to make sure that it doesn't break down in the gut. And all of the other medications ideally help increase that dopamine either by decreasing the breakdown of the dopamine in the brain or making it last longer. And then there are other types of procedural options, such as deep brain stimulation that Dr. Lazarus talked about for essential tremor, that also is an option for Parkinson's disease, and the focused ultrasound, focus guided ultrasound.
Mhm.
Hmm.
Yeah.
And so tell me about that. So what does that do? Like, so when we think of ultrasound, we think of babies, right? So our audience probably thinks of babies, or, we may think of, looking at certain body parts like kidneys. But so how is ultrasound used as an actual therapy?
So, essential tremor and Parkinson's, certain circuits in the brain are implicated. We know
Hmm.
what caused them. In fact, we know where the tremor cells are in the brain specifically. There are different areas for tremor and for Parkinson's. But if you destroy or inactivate that part of the brain, which is now not working the way it should be, you can reset that circuit and you can
Hmm.
control the symptoms. You can control the tremor. So, in deep brain stimulation, is one way of addressing that. A pacemaker, kind of like a cardiac pacemaker, is placed into that area, and when you run electric current through it, we think we're inactivating that area of the brain temporarily, as long as it's on. And that helps to like reset the circuit. But another way is to completely destroy that area of the brain. And so by focusing different rays of ultrasound at the same time on that spot, we can heat up that part of the brain and completely
Hmm.
destroy it. It's incisionless, so it's not surgery. It's just using topical or using ultrasound over the scalp to try to target that area. Um, but it should be thought of as permanent because you're destroying that area of the brain completely. So some patients may prefer not to go through full neurosurgery, full brain surgery, in which case it could be a real advantage. Deep brain stimulation, on the other hand, it is surgical. You are drilling a hole and you implanting an electrode, but parts of it can be reversible. If there's no immediate complications that happen, you can turn off the system, for example, and then revert to ultrasound if you need to. So it's either approach has advantages and disadvantages, really tiered to the patient.
Yeah. I think this is so exciting because I remember I remember when deep brain stimulation really became much more used, and definitely there was no focused ultrasound when I went through training. So it has really been amazing to see how treatment has advanced over time. I think we still have a long way to go.
Mm.
There was this movie. What was the movie called? Awakenings. They kind of talked about, when, Cinemed or carbidopa or levodopa, first became available, and all these people that were frozen were now, awake and able to move. I think it's just really fascinating and amazing to see how things have progressed over time. So, I always like to, kind of toward the end of our, episode, talk a little bit about what you're excited about or what are you working on? What kind of research projects are you guys working on, and what are you excited about in the field of movement disorders?
I think that the help understand the importance of research is that with respect to Parkinson's disease and it being so clinical, the best way that we learn is through research, through understanding the cause, the reason why people are having these movements, how they are affecting, and then helping with treatment options. And we have research, at least at Morehouse School of Medicine, of helping with all of that, or trying to learn about how to help all of those problems. We have a genetic study called PD Generation in conjunction with the Parkinson's Disease Foundation, where we provide free genetic testing to patients who have a diagnosis of Parkinson's disease. They also receive free genetic counseling where they learn about the results of their study, which is really, really unique. Most studies don't provide the results. And then not only do they get the results, they also get genetic counseling to tell them and help them explain and understand the results as well. We also have a study looking at people with exercise with Parkinson's disease, and if that helps treat or improve the symptoms, we know that the best treatment of yet to help slow down the disease progression is exercise. So we have a study called Sparks 3, and we're trying to help understand with people who are not currently on medication, so we call them de novo, with a diagnosis of Parkinson's disease within the last 3 years. If walking and walking on a treadmill helps improve their Parkinson's disease or decrease the progression of the disease. And last but not least, we also have a gene therapy study, and we are trying to evaluate a medication that may help people with Parkinson's disease who have a positive genetic test for GBA with that type of Parkinson's disease with medication. In the trial, they won't know if they have received the medication or not, but all of this helps to determine if we can treat the Parkinson's disease through exercise by slowing down the disease progression, or even through medication as well.
Amazing. What about you, Dr. Lazarus?
So most of my interest is around gait and balance associated with Parkinson's, and we talked about ataxia earlier. We have two studies that we're enrolling for right now. One is a treadmill-based study, which helps to identify biomarkers, so signatures of the disease, where we can predict patients who have greater risk of falling versus not, and hopefully where we can predict whether patients are progressing or not, disease progression or not. The second is, again, using a treadmill-based intervention called perturbation training, where we're testing out different forms of rehab that are essentially computerized and controlled to identify what works best for patients to slow down that disease progression and slow down their risk of falling. And lastly, we're hoping to soon be up and running with a spinal cord stimulator study, which is targeting specifically freezing of gait and mobility as a whole.
Yeah. So this is all so amazing. So, as you were talking, of course, it made me think of one more question before we go. Thinking about lifestyle modification. So here on Brain Chat, we love to educate our patient population, those who are living with neurologic conditions, care partners, etc. One of the things that I try to stress is empowering people to know what they can do to help themselves. So obviously, if you're having symptoms, you need to get checked out. But we talk a lot about lifestyle modification, and I heard you both talk about several exercise studies. So, are there lifestyle things that people can do, safely to help themselves if they are, dealing with a movement disorder such as Parkinson's disease or such as ataxia?
Yes, absolutely. We just talked a little bit about exercise as it helps with decreasing the disease progression, but exercise in general, right? It helps everything.
Right.
Other neurological disorders in general. Ideally, you want to kind of get out there and do some sort of activity, ideally 30 minutes a day for 5 days, which is a total of 150 minutes per week. But being active, doing getting that heart rate. The goal of the activity is also to increase your heart rate as well. Cardio has been shown to be the most helpful, although you can do strength training and yoga and things of that nature in addition to that. But when they're talking about that 30 minutes of exercise, we want to really increase your heart rate.
Anything you want to add,
Yeah,
Dr.
I
Rosemary?
agree, Dr. Bassett. And there's several kind of lifestyle interventions that we always try to discuss. Nutrition is one. I think the
Hmm.
Mediterranean diet is the one that people focus on. But if you had to choose one lifestyle intervention, exercise would be the one that has the most evidence, really the most science in our field. And so we always discuss that with our patients.
Yeah, so it's interesting with MS. Some colleagues of ours would say, that exercise is the most underdiagnosed disease modifying therapy. And there have been studies showing that it may slow atrophy or shrinkage of the brain over time. There's so many benefits, including the cardiovascular ones, but certainly it helps brain health, right? So again, most of our cardiovascular or heart healthy behaviors are also brain healthy behaviors: eating right, exercising, decreasing your stress. All of those things can make a difference, particularly if you're dealing with a degenerative neurologic disease. And last but not least, what about resources, right? So, I'm always an advocate of people getting information from solid or reputable sources because, on the internet, anything you want to find can be there, and some of it is not scientifically sound, some of it doesn't have a lot of data behind it. And so where can people go if they're dealing, we'll start with Parkinson's disease, where can they go to get information or to join or be a part of a patient community?
Yeah, we have the American Parkinson's Disease Association, and the acronym is APDA for Morehouse School of Medicine at Grady. I am the director of the APDA for Morehouse at Grady, and we have a phenomenal INR coordinator, Barbara Gatson. She has a direct phone number. They can reach out directly to her, and she contacts our anybody. It doesn't have to be a patient. It can be any individual. The American Parkinson's Disease Association has people throughout the United States and probably two in Canada. So that's a great resource.
Hmm.
And
Anyone you want to add?
yeah, the other organization, the National Parkinson's Foundation, so NPF is the acronym there, and mostly online based, but both them and the APDA have a very strong and active influence in Atlanta, so good resources for patients.
Yeah. Okay. Any parting thoughts? Any parting words of wisdom you guys want to leave with our Brain Chat audience?
Well, I think I'm most excited. You asked me a question
I
I didn't
do want to
actually.
add, I know we
So, sorry, Dr. Benz, after you.
you go ahead.
Sure. You asked earlier what I'm most excited about. I think
Hmm.
in the field, one of the things we're most excited about is just a few years ago, there really weren't many organizations or movement disorder neurologists in Atlanta, and now
Yeah.
the accessibility is so much greater. I think just about every major hospital system has a presence in movement disorders, which is a
Awesome.
reflection of how much a burden there is really in the city. But also, there's centers like Dr. Branson's that's a kind of a hybrid between academics and the community, but are reaching out to the community. So in the past where academic resources, research studies, clinical trials, education, advocacy were very hard to come by. I think it's much more visible now. That's the thing I'm most excited about.
And what about you, Dr. Branson?
Yeah, I do want to just to also add Parkinson's disease. We use Tremor as the first part of that acronym for TRAP. It commonly people with Parkinson's disease do not have to have a tremor. Based on previous studies, 25% of people with Parkinson's disease, especially early on, don't have a tremor. So often we can have these non-motor or prodromal, we call them, symptoms or problems. These problems can include mood, such as depression, anxiety, problems with sleeping, and things of that nature that people may not associate it with the disease and they may not talk about it. So I think that it's also important that we have those conversations within the community about some of the other problems that can be associated with Parkinson's disease as well.
Absolutely. So thank you both so much for lending your time and your expertise to talk about really important work. As I always say, hats off to my movement disorders colleagues. You guys are some of the most observant people, because the diagnosis of many of those conditions are so clinical, but we need people who are paying attention so we can make sure that we're getting it right, and addressing these issues, which can be very debilitating to our patients, even sometimes essential tremor, so I think, I'm so grateful for you all. I always say, if everybody's doing that thing that makes their eyes light up, then everything gets done. So thank you all so much for your time and your expertise, for sharing with us on Brain Chat, for sharing with our audience. And to those who have tuned in, thank you guys so much. And we will see you again in 2 weeks. Have a great one, everybody.
Thank you.
Thank you.
Thank you.